next one, Perfluoro in octane as short-term tamponade in pediatric rheumatogenic retinal detachment with PVR. Presenting author is Nawaz Sheikh. Dr.
Good afternoon, everyone. I'm Dr. Nawazish, and I'll be presenting our outcomes of Perfluoro N-octane as a short-term tamponade in pediatric rheumatogenic retinal detachment with proliferative vitreoretinopathy. So as we know, pediatric rheumatogenic retinal detachments, the success rate is as low as 50% because despite complex vitreoretinal interventions and heroic maneuvers that we do, keeping this in mind, our purpose was to evaluate our experience and outcomes of short-term tamponade using Perfluoro N-octane in pediatric rheumatogenic retinal detachments with proliferative vitreoretinopathy. So it was a retrospective analysis of children less than 12 years of age who underwent 25-gauge pars plana vitrectomy for pediatric RRD with PVR using Perfluoro N-octane as a short-term intraocular tamponade by a single surgeon. Only those patients were included who had at least 3 months of follow-up after the removal of the Perfluoro N-octane, and primary and secondary outcomes were assessed. So 9 eyes of 9 patients were included. The mean age of the patients was 8.66 years. The mean duration of tamponade of Perfluoro N-octane was 10.44 days with a range of 7 to 12 days. Coming to the primary outcomes, at the end of 3 months, 7 out of 9 eyes had reattachment after primary surgery, whereas the 2 eyes that had a redetachment underwent an additional surgery, of which only 1 succeeded, making it ultimately only 8 out of 9 eyes having reattachment at 3 months. That is roughly 90%. The secondary outcomes was there was an improvement in the visual acuity and no sight-threatening complications of Perfluoro N-octane in the form of corneal opacification or subretinal PFCL was seen in any of the patients. The first image is the intraoperative screenshot at the end of surgery with Perfluoro N-octane fill. The second image is the intraoperative screenshot during the second surgery where the Perfluoro N-octane was exchanged with silicone oil. We preferred silicone oil as we were expecting PVR and redetachment in these patients. They had PVR grade C onwards in these cases, so we went ahead and exchanged it with silicone oil. The image 3 represents the intraoperative screenshot of peripheral vasculitis seen during the time of removal of the Perfluoro N-octane. Thankfully, the patient responded to oral steroids. These are some of the images, ultra-wide field fundus images of some of the patients that had oil in situ. So as we say that pediatric RRDs usually present late, they involve the macula, there is a high propensity for PVR, and these children seldom take the positioning that is required following oil insertion. But there are properties of PFO such as optical clarity, high specific gravity, low viscosity, and immiscibility, which makes it a good tamponading agent, especially for inferior RRDs. But it is not free of complications. It can cause mechanical toxicity and intraocular inflammation, making it unsuitable for long-term use. In children, it helps us by allowing us an extended apposition of retinal tears to the RPE for strong chorioretinal adhesions to form. It's a better agent in patients having an inferior RD or breaks, as well as it shifts the cellular mediators of cellular proliferation away from the retinal surface as it's in close apposition to the retina. In case of a silicone oil, there is a small layer of aqueous fluid still present between the inferior retina and the oil bubble, where the cellular mediators of cellular proliferation may accumulate and cause PVR, causing a redetachment. But this procedure in children requires 2 stages. So general anesthesia has to be given to these children twice, which may be a problem in syndromic children. The 2 eyes that failed in our study had recurrent PVR, and they did not have an encircling element used in the primary surgery. However, a success rate of 78% at the end of primary surgery is very encouraging, especially in pediatric RDs. At the time of submission of this abstract, 5 out of 9 eyes had undergone SOR, following which another 2 eyes underwent SOR. So again, a 78% of success rate after SOR is a very encouraging result in pediatric patients. The limitations of our study was a small sample size. We did not have a long-term follow-up of these children, as well as no other studies, no other tests such as an OCT or an ERG were done to look for toxicity other than visual acuity in these children. The conclusion is that the rate of successful retinal reattachment was roughly 90% at the end of 3 months of PFO removal. PFO as a short-term tamponade is considered to be safe and effective in pediatric retinal detachments and PVR changes. Thank you.
Thank you. But there is no comparative arm, I think.
No, sir, there's no comparative answer.
So it would have been better if you were compared. The
Yes,
number
sir.
is small. Like eyes with silicone oil in
Yes,
one
sir.
arm, and eyes with
Yes, sir.
PFO in the
So
other.
we only attempted PFO silicone oil in patients in which we were anticipating a redetachment. Any patient who had presented to us with a giant retinal tear with PVR grade C onwards. So comparison between the two would have been difficult in that case.
And that too, the grades of PVR also, I
Yes,
think,
sir.
are different.
Yes, sir.
Yeah,
Okay,
my
thank you.
query was out of 9, 5 belt buckle encerclage was not
Yes.
used, I believe, no?
Ma'am, 5 encerclage was used.
Used.
4 it was not used. Out of those 4, 2 redetached. In the second surgery, both had an encerclage put in
You
place, but one
supplemented.
failed. Yes.
So there are multiple variables.
Hmm.
So
Yes.
comparativity is less.
Yes, sir.
Thank you.
Thank you so much, sir.